which are the risk factors for PDPH. We have divided these risk factors into patient-related, needle factors, procedure factors, and some miscellaneous. Patient factors include the age, gender, gravid status, that is obstetric patients, and psychiatric patients, BMI, history of previous headaches. Okay. Needle factors include the size of the needle, the type of needle, the angle of needle insertion, then the direction of the bevel while inserting, and the quality of the needle. Procedure factors includes the position of the patient, use of introducer, right? Miscellaneous is this is one factor that we have read is altitude. Now let's talk about the patient factors first. Which age group is most prone to have PDPH is the younger group, the age group of 20 to 40 years. Children and elderly, they tend to have less cases of PDPH, less incidence. Why? In children, it is postulated that firstly the CSF pressure is low, so even if you puncture it, the leak would be less. Secondly, lower incidence is attributed to lower reporting rate. Like the children cannot exactly always explain what is happening to them, so probably the reporting rate of PDPH is less. Older subjects, they have a few factors. Firstly, they have a high pain threshold. The reasons for it could be decreased A, delta, and C fiber function. These are the ones that carry pain, right? Then there could be decreased central sensitization, decreased elasticity of dural fibers, decreased elasticity of blood vessels. Because okay, first understand what is elasticity. Now elasticity, it's a concept of physics where if I take an object and put pressure on it, and then when I release the pressure, the tendency for this particular object to come back to its original place, like when I put some pressure, it got deformed, and when that pressure is released, it came back to its original place. That is what elasticity is. That is why steel is the most elastic. If you put some pressure on it, once you remove that pressure, it will still come back to its same shape, it will retain its shape. And rubber is the least elastic, because if you stretch it too much, it will not have, it has a tendency to come back, but not as much as steel. It will still be deformed. Okay, so similarly, if the dural fibers are less elastic, that means once they are cut, that retraction that happens and opens a gap from which the CSF can leak, that retraction is less. Okay, so reduced elasticity favors the elderly people, that the gap from which the CSF will leak will be less. In gender, for some reason, females are affected more. Hence, the most common profile that has the highest incidence is the young female. Amongst this, also a young female undergoing dural puncture for obstetric reasons. A gravid patient has highest incidence of PDPH. Why? Firstly, because this age group is of young female, right? Then because of their gravid status, they are more likely to be exposed to a dural puncture for a cesarean or epidural analgesia for labor. and hence they are more exposed to chance of a dural puncture and CSF leak. Other factors that contribute towards a headache are dehydration after labor, rapid changes in the blood volume, as well as the intra-abdominal pressure after delivery, and lack of post-delivery fluid supplementation. Certain psychiatric patients, like those with either chronic migraine or tendency to have a tension headache, if there is a history of prior PDPH, past history of headache after spinal anesthesia, their chances of developing a subsequent PDPH with a new lumbar puncture are also high. Then BMI, yes. People with low BMI have a higher risk of developing PDPH, thus, which means obese patients have a less incidence of PDPH, probably because their intra-abdominal pressures are high, and that creates a tamponade effect, and the CSF leak is reduced. Now let's talk about needle factors. Needle factors are probably the most important because these can be controlled. Needle factors are the one that is in our control. We cannot change the gender or the obstetric and the gravid status of a patient. We cannot change the age of the patient. But needles are what we can choose for a patient, and hence become very important to understand. The most important of it is the size. A smaller caliber spinal needle, or even a smaller caliber 2 needle, it was seen that any needle less than 18 gauze is good. Okay, so in spinal the ideal is usually taken as 24 to 27 gauze, and hence 25 gauze becomes the most go-to for those who are well experienced. Although when we are allowing our juniors to perform, we start with 23 gauze because it is thick enough that your loss of resistance with the ligamentum flavum and the dura, they are appreciated better with a thicker needle. With spinal needles you might not appreciate that loss and resistance and that giveaway feeling. So for training purposes, we do start with 23. But once you have learned, like when you are in second year or third year, if you have to give a spinal, try to give it with a 25 gauze spinal needle. So a smaller caliber size is associated with less incidence, which is pretty obvious, right? The CSF leak, the dural puncture size, that is less, and the CSF leak is less. There is a less chance of PDPH. Then the type of needle. There are two types of spinal needles. Okay, one are the cutting type. They are the one with a bevel, and the edges of that bevel are sharp and cutting. They include your Quinky and Pitkin. Okay, when I say bevel, this is what I mean. Okay, this is the opening. The opening is slanted, and there is a stillet inside it that completely occludes this lumen. Now these edges of the bevel, they are sharp, and when this needle is encountered with the dura, it will cut the dura, and that cutting will cause retraction because the tension is longitudinal, and from that there will be a defect, and from that defect CSF leak happens. In comparison to the spinal needles which are pencil point or have a conical point, conical end. These include examples are Green and Whitaker, also Sporret. These have a conical end. Okay, so because of their conical end and these edges being atraumatic or non-traumatic, or they are not sharp. And see, here the opening is at the end, right, in the cutting ones. In these pencil points, the point is occluded, it's completely closed. The opening for the drugs is on the side, and because of this, since they are atraumatic, since they are not sharp, it's postulated that when this is encountered through a dura, the dural fibers separate, they do not cut, and hence, because they separate, the hole first of all is not that big. Secondly, it will not be a complete rent, so there won't be a CSF leak later on once we remove the needle. So the incidence of PDPH was far more in the cutting edge as compared to the pencil ones. Hence, the ideal spinal needle would be of a smaller pencil point needle. But in practice, it is seen that of these two, size matters more. So if you have a choice between a small cutting spinal needle versus a large pencil type of spinal needle, choose the small cutting one. This can be a potential viva question. They can give you two different needles and they would say which one would you choose and why. Okay, so that's what they want to know, that do you know that PDPH is associated with a larger caliber needle and hence you should choose the smaller one even though if it is cutting one, because if you have good hand skills for a spinal needle and you are not repeatedly puncturing the dura and it's not that difficult of a spinal, then if you have used smaller gauze needles such as 25 or 26 gauze, then the chances of PDPH drops exponentially even if you have cut the dural fibers. Another needle factor is the angle of needle insertion. If this is my dura, okay, this angle would be 90-degree approach, then this would become 60-degree and further oblique 30-degree. It was seen that more oblique you go, the rent in the dura is more oblique and that forms a flap type valve condition and hence this dural puncture becomes self-sealing. And so the persistent CSF leak is far less. If you go exactly 90-degree, this opening would be more and CSF leak might be more. Then comes the bevel orientation. Again, I told you the bevel, this one, right? If this bevel is oriented parallel to the longitudinal axis, then it is postulated that even with the cutting edge, less dural fibers would be cut. But this was based on the assumption that dural fibers are longitudinally aligned. But I told you in the beginning that they are not longitudinally aligned, they are aligned in laminas and they are aligned in concentric circles. So basically, the longitudinal tension that is present in the meninges, if you keep the bevel parallel to the longitudinal axis, then the retraction of these dural fibers will probably be less. And that is why there was a clear-cut observation that the bevel orientation parallel to the longitudinal axis in comparison to keeping it perpendicular had less incidence of PDPH. Another point is the quality of needle. When I say quality of the needle, I mean that a needle whose end is smooth, the stillet inside it occludes this lumen perfectly. Like the if I enlarged make an enlarged view of this bevel, right? The stillet and the bevel should oppose each other, should fit each other perfectly. There should not be a gap in between these two. Why? Because if there is a gap, the moment you withdraw your needle back, a strand of your torn edge would come out with the needle as a wick, like the wick of a candle. Okay, so and that would cause a situation like this. If this is a dural puncture made, this is the wick standing out, right? So there can be a persistent CSF leak. If they are properly opposed and this wicking does not happen, less open, the dural puncture would be less severe and less CSF would leak. And for the same reason, these should oppose each other properly. there should not be any burr at the point of the needle. And how do you check for this quality? You check it by, first you check the flexibility. It should not be very brittle. Flexibility of the needle to be checked. Then you take the needle with the stillet and you thrust it through a sterile gauze. Okay, so here we are using gauze as a simulation for dura. And when you thrust it through and you come back and you see, if you see that some cotton strands are caught in this space between the stillet and the needle, then the quality is poor. And what has happened with the gauze can happen with the dura as well. So you need to change the needle. What are the procedure factors? One is the position where if we are hyperflexing the patient during an LP, then the dura is stretched more. And if the dura is stretched more, it will retract more after the puncture and the opening will be big and there will be more CSF leak. If we have used an introducer, it minimizes the contamination of the deeper structure, okay, and the subarachnoid space. Experience of the performer. If you are performing, if you are doing, trying to reach the subarachnoid space again and again and you are missing it, there are chances that you would make multiple small dural punctures and they can leak CSF later on, and more risk for PDPH happens. Then if you have threaded a catheter or not. It was seen that in cases of continuous spinal anesthesia, where catheters were used in the spinal space, you would assume that in order to thread a 20 gauge catheter, you use an 18 gauge Tui's needle, right? And if you have punctured the dura with an 18 gauge Tui's needle, you would expect there to be PDPH. But it was observed that even though you used an 18 gauge needle to puncture the dura, catheterizing that space, threading the catheter, was associated with reduced cases of PDPH. This was attributed to aseptic tissue reaction, which leads to some exudation and edema at the site of the dural puncture, and that sort of seals the defect, and there is less CSF leak. With the miscellaneous ones we read altitude, it's somehow seen that at higher altitude the PDPH is more. Now, what are the risk factors in a situation where you have done an accidental dural puncture or inadvertent dural puncture while performing an epidural procedure? This is probably one of the most common scenarios that a resident would face. Okay, so I am talking about the risk factors that would contribute towards PDPH in a setting where you have already done an accidental dural puncture. If you are to ask about reducing the risk factor while doing an epidural, well, don't puncture the dura first. Okay. So, but if you have punctured the dura, you saw that CSF coming. Now, what are things would matter? Firstly, the needle size would matter. If you have used 18 gauge needle size, there is less chance that PDPH would occur. Well, 18 gauge is very big, there are chances, but if you have threaded the catheter, it won't. But this, like 18 gauze is like, if it was compared with bigger ones, the 16 gauze or 14 gauze, because initially the concept of finer needles was not present. So in comparison to these big wide needles, puncture with 18 gauze was associated with less incidence of PDPH. Then bevel orientation made a lot of contribution. If it is parallel, the rate of PDPH was significantly less. That is why it is recommended that The bevel should be oriented parallel to the dural axis while during an epidural as well. But the problem with it is difficult to thread the catheter through it. Like the catheter might migrate through the intervertebral foramina and out of the vertebral canal. So most of the people, what they do is they go parallel, and once they think they have crossed the subcutaneous tissue, and now they have to start detecting the epidural space with an LOR, they turn their needle 90 degrees. Now, this turning is not supported by everybody. A lot of people think that if I turn this, I might lose my epidural space, I might cause even more damage to the dura. So, many people are confident with going perpendicular only, and they don't turn their needles, and they prefer that they don't puncture the dura in the first place. Role of bed rest. Now, paradoxically, like you have must have seen, anyone with the risk of PDPH is asked for a bed rest. It was seen that bed rest was paradoxically associated with more cases of PDPH, forced bed rest. Early ambulation was associated with less PDPH. So, early ambulation, as the surgery would dictate, as the surgery would allow, okay, that should be practiced. Along with this, you can ask the patient to avoid any straining, any heavy lifting, because even if there is a rent, any heavy lifting would increase the intradural pressure and more CSF could be lost. Now here I want to address one little thing. What would you do in a scenario where you have punctured the dura? Now you are standing in the OT, you are given the huge opportunity of performing an epidural catheter placement today before the OT. Now the surgeon is waiting for you, your professors are waiting for you. It's a glorifying moment for you, but you are terrified, and in that nervousness you do an LP accidentally, and you see that in your LOR needle there is some clear fluid coming uh, with a good gush, and you know that it is CSF. You know that you have, it's your oops moment and you have accidentally punctured the dura. So what do? The first thing that you do is that you do not panic. It's fine. Okay, even if you have punctured the dura, even if the patient gets a bit of PDPH, it's fine. If you panic, if you move your needle a lot, that will cause even further trauma, and you don't want that, because one thing you don't want, which is worse than a PDPH, is spinal cord injury. Anyways, if you are putting an epidural, you would be in L1 L2 space or L2 L3 space, right? You are near the spinal cord, the main chunk of it, so you don't want your needle to be moving here and there, and you don't want to panic and cause more harm to the spinal cord. So what you do is you do not panic, and you leave the needle in place with the stillet, or I should rephrase this. The best thing that you do here is you replace the stillet and you leave the needle there. Just keep your hands back and take a good breath, good deep breath. It's fine, it's already done. You just have to manage it later on. Just don't make it worse. So just pick up your stillet, put it back, and just leave your hands and take a breath, and then understand what is the next step to be done. The next step to be done is nothing but to do another epidural in a different space. Okay. Another thing that you can do here is you abandon the epidural altogether and you give your drug in the spinal space, and you don't put an epidural at that point of time. You can do a procedure later on, or you could just abandon the epidural altogether. Okay, or you could just come out of it, leave that space, find another space, thread your catheter in another space. Obviously, you call for help. You call your seniors if it's a difficult epidural. And if you have punctured it once without any supervision, it's better to call somebody so that they can stand and they can point out whatever mistakes you are making, and whatever you do, just don't panic, don't make it worse, and understand this situation can happen to anybody, and just take it easy and breathe. Before going to the treatment, we'll first discuss the preventive measures. So, first is that you properly counsel your patient, you take a good consent, good written consent, and you explain that such a possibility can happen and it's nothing to be really scared of, because epidural patch or no epidural patch, it is anyways, it spontaneously resolves in most of the patients. Okay. PDPH has been a very common cause of litigation, especially in US, and Indian public would catch up soon. So a written consent and explaining about the PDPH in the most mild and empathetic way should be done. Then adequate hydration. Although adequate hydration is now under controversial topic, whether it helps or not. But since dehydration was associated with more PDPS, that is why it is said that the patient should be well hydrated even before a lumbar puncture. And if at all there's an accidental puncture, you maintain dehydration. But still, evidences of prior adequate hydration reducing the chances of PDPH, that is not very convincing. Most important is use a small caliber needle, and you keep your bevel orientation parallel or longitudinal to the long axis. If possible, use an introducer. Okay. You encourage early ambulation. Bed rest is not advised now. Okay. Then try to maintain the spinal fluid volume, and that can be done with adequate hydration. Okay, that can be done with correction of any hypotension if it is present, often seen postpartum and post-spinal, and you replace any blood losses of the surgery. Now, one more observation was seen that uh, if you put the stillet back in the needle before you withdraw your needle, like we usually inject the drug, we detach, some of us, we detach the syringe and we see that the CSF backflow is still present, we confirm that we are still in the spinal space, we attach the needle back and we remove the whole thing. If you want to reduce your chances of PDPH even further, what you can do is you can just put the stillet back, and as you had inserted your needle, you remove the needle completely. Why? Because again the bevel will be completely closed, and that wicking of dura, that doesn't happen. The epidural saline injection. It was noted that after an epidural or after an dural puncture as well, if you would inject a few mLs of saline in the epidural space, that could basically create a tamponade, or even you could say in some way contribute to the CSF volume that has been lost or that would be lost later on with the rent. That could cause reduced loss in the CSF volume and maybe less PDPH. It is also used as one of the treatment modalities, but it was also not very effective. All these preventive measures that I have told you of, these using a small caliber needle and distillate, using a small caliber is really very effective. Rest of them are hazy, the evidences are patchy,